So on to tonight's topic. So the topic is the causes of subfertility. We're moving our way through different topics. We're lucky enough to be joined today by the Newlife IVF fertility specialist, Dr. Jatkar, and Dr. Amber Kennedy. If you've got any questions, just remember that there's a Q&A box at the bottom, and if you fill in questions there, we'll ask our panelists these at the end, and we'll go through all the questions at the end. So now I'll present our first speaker, Dr. Amber Kennedy. Through.
Hello, everyone. Thanks, Hugo. Welcome to our webinar tonight, where myself and Dr. Jatkar are going to be talking to you about the causes of subfertility. Now, when I think about subfertility and all its different causes, I like to think about this very detailed, confusing and overwhelming diagram, illustrating all the different things that need to go just right in order to conceive naturally. When you look at this diagram, you can see, as Hugo mentioned in the webinar last week, that why we only see about a 20% chance of conceiving naturally per month in all couples. So in order to conceive, you need a good quality egg to be released. You need that egg to be picked up by the fallopian tube. You need sperm to be there ready and waiting. You need the egg to be fertilised. You then need the embryo to travel down the fallopian tube to the endometrial cavity, all the time dividing and beginning to develop, at which point it reaches the endometrial cavity. You need a receptive endometrial lining and then implantation to occur. So you need the right egg at the right time with the right sperm, and you need a functional tube and the right endometrium. And at any point in this pathway, things can go awry, leading to our causes of subfertility. So I'd just like to talk about some definitions. There has been a trend recently towards using the term subfertility as opposed to infertile or infertility. And that's because those terms are very black and white. They don't appropriately describe or represent the different spectrum of failure to conceive or difficulty achieving pregnancy. Also, the term subfertility is a much more hopeful one for our patients. So looking at primary subfertility, which we define as failure to conceive after 12 months of regular unprotected intercourse where no previous pregnancy has occurred, we see that this occurs in about 15% of patients or couples. Although it is worth mentioning that about half of these patients will actually spontaneously conceive if they continue to try naturally for a following year. Secondary subfertility is similar in that it's failure to conceive after 12 months of regular unprotected intercourse where a previous pregnancy has occurred regardless of the outcome. So if we break down the different causes of subfertility in heterosexual couples, about 30% of the time we find that the female partner is diagnosed with a cause of subfertility. About 30% of the time the male partner a cause is found. 30% of the time there's either mixed factors or both members of the couple have a diagnosis. And 10% of the time we don't in fact find a identifiable cause, and this is called unexplained subfertility. Now, of course, the desire to be a parent is not exclusive to heterosexual couples, and some other common causes of infertility are either being single or being part of our LGBTQI community. So now I'm going to focus on the female factors or factors that arise from the female reproductive tract. About a quarter of women suffering from subfertility suffer from polycystic ovarian syndrome. A quarter of women suffer from an ovulatory disorder, And this can be something like polycystic ovarian syndrome or PCOS. There could also be a condition called hypogonadotrophic hypogonadism, which is a bit of a mouthful, so sometimes we would just refer to that as hypo-hypo. This is a condition where the body shuts down ovulation in response to stress, excess exercise, or low total body weight. There can also be other endocrine or hormonal disorders, as well as an elevated BMI that can impair regular ovulation. Unfortunately, some women that we see suffer from a condition called premature ovarian insufficiency, or POI. This is a condition where a young woman's ovaries act as though they are menopausal and they stop producing eggs. This can be seen in women who have undergone cancer treatment and had chemotherapy. Next, we have tubal abnormalities, which can either be in the form of a tubal blockage or pelvic adhesions, which actually impair tubal function by reducing their mobility, so they're unable to freely pick up the egg after it's released. These can be caused by endometriosis, pelvic infections, prior pelvic surgery, or a previous episode of appendicitis. Next, we have uterine causes, which can either be congenital, meaning that you were born with a condition, or acquired, such as a condition with fibroids, which fibroids are benign, smooth muscle tumours of the uterus. These can impact fertility, but only if they are numerous or large and impacting the internal endometrial cavity or distorting the shape of the cavity. We see some patients with a rare condition of scarring within the uterus. This is called Asherman syndrome. And there can also be disorders of the lining of the uterus called the endometrium. This could be endometrial hyperplasia or disordered growth of the lining, or endometrial polyps. Both of these can impair implantation. Endometriosis, actually, even though I've already mentioned it, it gets its own category, and it does impair tubal function, or it can impair tubal function, but it also can affect fertility in multiple other ways. To name a few, endometriosis can cause chronic inflammation, which can affect the embryo and impair implantation. It can cause painful sex, which makes conceiving naturally very difficult. And sometimes we see women with endometriosis having reduced ovarian reserve or egg numbers. And this is because of either surgery to treat their endometriosis or endometriomas, which are cysts of endometriosis that form within the ovaries. And finally, and unfortunately, the last thing to discuss in terms of female factor subfertility is increasing age. Maternal age is the single most important determinant of a couple's fertility, and this is because of falling egg reserve and reduced egg quality. This graph, which we showed a similar one to last week in our webinar, illustrates the impact of age on your ability to conceive. It was produced by a data analyst who tried to model the chance of conceiving, or the cumulative chance of conceiving, using just the age-specific monthly fecundity rate. As you can see, at age 25, that rate is 25%, and pretty quickly the cumulative chance of conceiving is pretty high. If you compare and contrast that to a woman at age 40 or even 45, where the monthly fecundity rate is much lower, the cumulative chance of achieving a pregnancy is significantly reduced. This graph, in fact, is actually a little bit optimistic because it doesn't take into account any other causes of subfertility, and it just models the effect of age alone in fertile women. Illustrating this another way, this graph demonstrates the chance of successful conception per month or per cycle. The purple line represents your natural fertility or natural cycles. And as you can see, from about age 30, this chance from about sort of 20 to 30% starts to decrease quite significantly. And taking age 43 as an example, the chance of spontaneous pregnancy per cycle is around 2%. Now we add on the success rates for IVF cycles or different IVF cycles. So if we look at the orange line, this is representing IVF cycles using own eggs. So the woman is using her own eggs for the cycle. And whilst the success rates per cycle are greater than with natural fertility, the curve is very similar and declines quite significantly with advancing age. If you compare and contrast this to the blue line, which is representing the success rates per cycle of, or per transfer of donor egg cycles, you can see that the success rate of conceptions is holding steady at about 50%. This illustrates that the reason for the decline in the success rates for age is due to the age of the egg. And finally, unfortunately, the decreased chance of conception is not the only thing that occurs with advancing age. And we also see a significant increase in the risk of miscarriage as the woman becomes older. Again, taking 43 as the example, we see miscarriage rates as high as 55%. Okay, I'm now going to hand over to Dr. Samir Jatkar, who's a fertility specialist with Newlife IVF, and he's going to discuss male factor infertility as well as combined and unexplained subfertility. Thanks.
Alrighty, thanks very much, Amber. So as Amber mentioned, today I'll be talking about the various factors that can affect the male partner in a couple, leading to subfertility. As we alluded to earlier, 30% of patients have, or couples have that as their primary reason for their subfertility, and up to 50% of partners have a male factor contributing to their situation. So, although there are lots of tests related to male fertility, the most fundamental test is the semen analysis. We perform these on site, so allow the male to produce a sperm sample on site in our lab. Alternatively, people can produce a sample at home and bring it to the lab. And there are a number of factors that we look at, all of which contribute various information about the function of those sperm. So, the most fundamental is how many sperm are there, and that's an assessment of the concentration of sperm per mil. Traditionally, we say, and it's guided by the reference ranges of the World Health Organization, that you need 15 million sperm per mil of the ejaculate in order to conceive naturally. Similarly, we look at the overall number of sperm in the ejaculate, and we say that you need about 40 million or more to be considered normal. And the motility, how those sperm are swimming, either the forward progression or the numbers that are moving all together, so the total motility. And finally, we also look at the morphology, which is the shape of the sperm under the microscope. Now, interestingly, the shape of the sperm, we only need 3% or more, 4% or more to be normal shape, to be considered normal. So that's normal for us as a species. If on the semen analysis we see no sperm as well, that's a condition called azoospermia, and also no sperm or semen is aspermia. Now, that's the most fundamental analysis. We can do more sophisticated tests, things like DNA fragmentation and mucus penetration, but we only do those in select cases if there's an abnormality on the semen analysis or other clinical scenarios. So when we think about male factor infertility, we think of it with a sort of a schema, which is pre-testicular, testicular problems, or post-testicular, which are respectively the brain failing to send adequate signals to the testicle to work. The testicular causes are the testicles not producing sperm correctly, and the post-testicular causes are obstruction to sperm getting out into the outside world. So in terms of the pre-testicular causes, they're actually relatively uncommon. It's probably less than, it's a single-digit % of males who present with the reduced sperm counts due to the pituitary not telling the testicles to work through the production of FSH and LH. And that can be inherited. It's a condition called Kalman syndrome. And sometimes it can be due to other endocrine disorders, disorders where there's too much prolactin production and disorders of the thyroid gland. Also, some medications can be associated with suppression of the pituitary. More commonly, we see testicular factors, and that's where the testicles themselves aren't producing sperm correctly. In this particular diagram, we see that there's a number of steps for the germ cell to produce a functioning sperm, and that takes about 72 days in the male. And during that time, the sperm change in shape and the number of chromosomes, and finally acquire the tail and motility. And errors can happen along the way through that process. In terms of causes, often we don't know, but we know that mumps, particularly when it's acquired as a teenager, can profoundly affect the production of sperm. There are some things that are inherited, so chromosome problems, the classic being Klinefelter's syndrome, where the production of sperm is quite severely reduced from the late teens onwards, and Y chromosome microdeletions, which can be inherited from the father, the Y chromosome being responsible for the genetic code for sperm production. More importantly are the latter two in terms of things that we can do to improve this semen analysis and the sperm function. Now, although there's been some controversy over whether varicoceles, that is dilated blood vessels in the testicles themselves, can cause abnormality, we're coming to the consensus that if there's an abnormal semen analysis and a varicocele present, that the treatment of that varicocele through a surgical procedure done by a urologist can help the sperm production and sperm function. And the mechanism behind that is the buildup of toxins and the buildup of heat in the testicles. Now, the testicles are outside the main part of the body because sperm production is optimum at 35 degrees. Hence, sitting with your laptop on your lap, heating the testicles, and some sorts of exercise, and in particular long bike rides, can raise the testicular temperature and cause an impairment in the sperm production. And finally, there are those post-testicular causes. Now, interestingly, the most common cause of obstruction is previous vasectomy for people who thought they were completing their family, but then decided to move forward and have another child. But we also see it associated with people who are carriers of the cystic fibrosis gene, where the vas deferens, which carries the sperm to the outside world, doesn't form. In terms of the other factors that could be involved in male subfertility, well, idiopathic is quite common. Idiopathic means we can't identify a reason. Sometimes it is that it's an exposure that's been in the past that has been long-lasting, like mumps, and that essentially is a diagnosis of exclusion. We know that age does affect sperm quality, not quite as profoundly as it does affect egg quality, but certainly it is a factor. And there are a number of other conditions, such as retrograde ejaculation, where instead of the sperm coming into the outside world, they go backwards into the bladder, and of course erectile dysfunction and the inability to achieve an orgasm through intercourse due to the male factor affecting fertility. Now, as I mentioned earlier, the reality is that we see a lot of patients with combined factors. That is, some subfertility contributed by the female factor and some from the male factor. And I see this very commonly. For instance, if you have the male with just a borderline motility but an adequate count, and a female who might be of more advanced age when she's trying, that would be enough when combined to make that couple infertile or subfertile. Similarly, if you had a borderline semen analysis parameters and only one tube, again, that can be one fallopian tube patent, that can be a cause of subfertility. And of course, there are other factors such as the inability to time intercourse correctly to the fertile time and the inability to achieve penetrative intercourse. And finally, there's the category, and I must say it's a moderately large category that we see of patients where after the full workup of both male and female infertility and a good battery of tests, we actually don't identify a specific cause. Now, this could be that statistically speaking, they're in that category who are otherwise normal and may conceive with further time. They may also be in the category where there's some other factor that we just can't measure with our current technology. And the definition of unexplained infertility is 12 months of well-timed intercourse in the presence of a normal semen analysis, regular ovulation, and both fallopian tests being patent. Now, in terms of what other investigations might one do during to make the diagnosis of unexplained infertility, well, to truly exclude endometriosis, some would suggest a laparoscopy to exclude that. Others would say, well, if you're in this particular circumstance, that actually moving on with formal fertility treatment is also a reasonable option in the absence of a laparoscopy, because we do know that patients with unexplained infertility and who are not of already advanced age actually do extremely well with certain types of fertility treatment. And finally, we're going to be opening up the forum for some questions. And Amber's just going to join me as well for that.
Hi. So we have some questions to answer. The first one is, I have regular periods. When should I see a doctor? It's a good question, because usually we say try to conceive naturally for up to 12 months before seeing a fertility doctor. Although if you are over 35, we would probably reduce that to around 6 months. However, if you don't have regular periods, this means that you are not ovulating regularly, and it can mean it's very difficult to fall pregnant naturally. So if you have irregular periods, then we would recommend seeing a fertility specialist straight away when you're trying to conceive.
A question that's come in is a patient who's had an abnormal sperm test, and what are the next steps from there? Well, the first thing to emphasise is that you can't really diagnose male infertility on a single test. You ideally would like to do another test 6 weeks later, and that comes back to the fact that it takes that 72 days for a new batch of sperm to come through. And ideally, we'd want to also have that repeat semen analysis done at an andrology lab, so a place that does semen analyses all day, every day. We do that at Newlife IVF. There are other andrology providers, just to make sure that all of the parameters are being recorded in the best possible way. If that second test does confirm an abnormal or persistent abnormality of the semen analysis, then there's a number of tests from there. I would perform a series of hormone tests to ensure that the pituitary gland's working, including testosterone and hormones such as FSH and LH, a thyroid test, and a test of the prolactin. All of those things that can suppress normal sperm production. I usually order an ultrasound of the testicles as well to make sure that we're not missing something that might be going on within the testicle itself. There are other more advanced tests such as DNA fragmentation, those mucus penetration tests that I mentioned earlier, as well as post-ejaculatory urine analyses for when we're suspecting those more unusual causes.
Okay. Another question that we've had come in is, what is the likelihood of falling pregnant after experiencing an ectopic pregnancy where the tube was removed? That's the first part of the question, which I'll answer first. So in a natural cycle or a naturally conceived pregnancy, we actually find that removing the tube, you would think, reduces the chance of conception the next time by about a half. However, the tube from the normal side is actually able to pick up the egg that has been ovulated even on the abnormal side. So there is a slight reduction in the monthly chance of conceiving of about, I think it's 70% in the next cycle compared to if you had both tubes. However, the reason for the ectopic usually applies to both tubes, and so anyone who has had an ectopic pregnancy is at risk of having an ectopic pregnancy in the next pregnancy, and we would recommend having early ultrasounds in that pregnancy in order to diagnose hopefully an intrauterine pregnancy early on. The second part is that if this occurred during a previous IVF cycle, is there a chance that it would reoccur? The chance of an ectopic pregnancy would be less in an IVF cycle, as we do our embryo transfers under ultrasound guidance, and we deliberately place the embryo within the endometrial cavity in the correct position. Unfortunately, sometimes they still do travel up the tube and cause an ectopic pregnancy, but the risk of this would be lower.
The next question I've got is, if you've had a previous vasectomy and a new partner, what options are there to conceive? Well, broadly speaking, there are two options. There's a vasectomy reversal, which is usually performed as a microsurgical procedure to essentially replumb, remove the obstruction and re-establish the vas deferens so that conception can happen naturally. The second option would be using IVF with a surgical sperm retrieval, and that's where we take the sperm directly from the testicle to allow us to use it for the IVF process. Now, which of those two options is better is a fairly detailed discussion, and it usually revolves around a full evaluation of both partners, including the female partner, simply to know what the chances would be from IVF, and also to know if there are any other reasons that that couple might need IVF anyway. So for instance, if the female partner had blocked tubes and the male partner had a vasectomy reversal wouldn't be appropriate, because even with ample sperm returned to the ejaculate, that couple is unlikely to conceive. The next question I have is just regarding the current situation and what treatments can we offer. So as Hugo mentioned earlier, we are a little bit constrained on what we can do, and we think that's appropriate just from a resource point of view at the moment with everything that's going on in the world. However, so that means that for people who are in cycle, they can complete their frozen embryo transfers, they can complete their intrauterine insemination, and they can complete their IVF treatment. Ovulation induction does fall outside of the definition of elective surgery, so we are still able to offer ovulation induction either with tablets such as clomidol letrozole or with FSH injections. Now, it is important that our information from the government and the health department is changing on a day-to-day basis, and that is current information. It is a bit of a moving target at the moment, so ovulation induction is still definitely something that we can offer.
The next question is, can pharmacy LH ovulation test kits be used successfully by women with PCOS? And the answer to that is sometimes, but often you can get false positives in the case of PCOS, as women who have PCOS have a high baseline LH level, and often this level is above the threshold of many pharmacy LH kits. So if you get a negative result, then a strong positive, and then another negative, then you can pretty safely say that you've detected your LH surge. However, for example, if you started testing and the test came back positive early on in the cycle, then it would be most likely that that is not a true surge and that the LH ovulation test kit is not going to work for you. Thanks everyone for sending in your questions. Keep sending them in because we do have some more time for questions.
Now, I've got a question from a viewer regarding what are the causes of multiple very early miscarriages. So interestingly, the definition of recurrent miscarriage has changed somewhat. When I started out, it was 3 early miscarriages, and nowadays most of the international societies are recommending a full evaluation after 2 miscarriages. There are lots of potential causes both on the male and female side. Start with the easy one. For males with lowered semen parameters, there is some association with poorer pregnancy outcomes. We also know that patients with poor sperm parameters as well as high DNA fragmentation in the sperm have a greater chance of miscarriage in the first trimester. However, on the female side, there's a number of conditions, and I break them up into really genetic conditions, physical or anatomical conditions, as well as endocrine conditions. So one that we see moderately frequency is if your chromosome count, and we all have 46 chromosomes, has an abnormality called a translocation. That can lead to imbalanced chromosomes in pregnancies and is a classic cause of recurrent miscarriage. We can test for that on a blood test, and we routinely do that for patients who've had multiple miscarriages. The next broad category is endocrine and immune factors, and very specifically patients who have underlying endocrine disorders with the thyroid or diabetes can suffer multiple miscarriages. There is some controversy about blood clotting disorders contributing to multiple miscarriages. However, there's one in particular that has been shown to be clearly associated with multiple miscarriage, and that's called the anticardiolipin antibodies or lupus anticoagulant, and that is an immune-mediated problem. And again, that's can be tested on a routine blood test. The final factor in terms of anatomy is then, well, what physically is going on with the uterus and tubes. Some factors like having a slightly variant shape to the uterus, what we call a uterine septum, or fibroids impacting on the cavity itself can potentially contribute to miscarriage. And so we can do various forms of imaging on the uterus, as well as looking inside directly with cameras, a process called a hysteroscopy. So it is quite a thorough process to try and evaluate what are those various factors. And of course, the main factor that we do see is the impact of advanced age.
Okay, another question has come through about how common is tubal blockage and how do you test for it? So we see some form of tubal abnormality in about 30% of women who have female factor infertility. And that can either be, as we mentioned in the presentation, tubal blockage or tubal immobility or scarring and adhesions that can affect tubal function. There are 3 different ways that we can assess the tubes. The first way is by an X-ray, which is called a hysterosalpingiogram. This gives us primarily information just about whether or not the tubes are blocked or not. It doesn't give any information about the anatomy or the presence of adhesions or scarring. The benefits of this procedure are that it's usually done as an outpatient. It's done with you awake, and you can get the answers immediately. Another version of this test is called a hycosi, which is an ultrasound version where, again, the patency of the tube is determined via an ultrasound. The third way, which gives us the most information, is via laparoscopy or keyhole surgery, where again we try and flush the tubes with a dye to visualize the dye coming out the end of the tubes, confirming that they are patent or not blocked. The benefits of this method are that we can visualise the tubes, see that they are free and mobile and not affected by any pelvic adhesions. Of course, this is a surgical procedure, and so the downsides would be that it's much more invasive, does often require admission to surgery overnight, although it can be done as a day case, and requires a general anaesthetic.
More questions regarding multiple egg collections. So the question is, if you have multiple egg collections, can you damage the ovary? The short answer is, well, overall, it's a very, very safe procedure. So we see people with multiple procedures who have no effects on the ovary or on fertility. And the main thing is that it's important to keep in mind we're collecting eggs that otherwise would have been lost in any one menstrual cycle. We're not depleting the overall number of eggs in the ovaries compared with just the natural passage of time. And the chance of complications from an egg collection being a fairly straightforward procedure are very, very low. Now, of course, we are very careful when we're doing the egg collections, and we do them under ultrasound guidance not to affect any surrounding structures. In any surgical procedures, there are just small, very, very small risks of bleeding and infection, but in this particular procedure, that's fairly rare. Now, the next question I have here is about if you're getting regular periods and getting normal ovulation results, and I presume that's from the urine kits, is there a reason for that? Well, the short answer is pretty much everything that we've talked about the combination of male and female factors. So when I talk to my patients, I always say there's 4 things you've got to tick in order to conceive. That is, you've got to be ovulating, so releasing the egg regularly, tubes being open so sperm and egg can meet, a normal uterine cavity, free from polyps, fibroids, anything that's going to stop the embryo implanting, and the right amount of sperm at the right time in the cycle to conceive. So if you've got regular ovulation, you tick one of those 4 factors, but I really would suggest evaluating the other factors before saying that to determine if there is anything else going on. Alrighty, so I think we've answered all of the questions that we've had come in today. So thank you everyone who did write in their questions and join us today. Next week, we have another part in our series Fertility 101, and it'll be Chris and myself talking about the initial fertility management, including the options of ovulation, induction, artificial insemination, tubal flush and surgery. So hopefully you're able to join us for that. And thank you for joining us tonight.